The process I chose was acute respiratory failure. Acute respiratory failure is when you have difficulty with gas exchange and/or ventilation. There are also two different types. The first type I'm going to talk about is hypoxemic. With hypoxemic, you have a problem with ventilation or perfusion. In the textbook, it describes it as a mismatching of ventilation and perfusion occurring when areas of the lungs are ventilated but not perfused, or when they are perfused and not ventilated. The second type is hypercapnic. This is when they can't maintain alveolar ventilation, causing them to retain carbon dioxide. This leads to hypoxemic. An example of this would be a COPD patient because they retain carbon dioxide and hypoventilate, which puts them at risk for hypoxemic acute respiratory failure. Incidence and prevalence. Between 1/5 and 1/3 of clients that have acute respiratory failure will die in the hospital. I consider this to be a fairly high mortality rate, and mortality rates get even higher in patients that are 85 and older. Trauma-related acute respiratory failure is mostly seen in patients 30 or older. If a chronic lung disease is the cause, this is mainly in patients over 50 with the exception of asthma. With patients with asthma, the age group that acute respiratory failure is more prevalent in is 5 to 17 years old. There are many risk factors for acute respiratory failure, such as pneumonia, sepsis, and COPD. Some other risk factors are aspiration, alcohol abuse, cigarette use, and African Americans. Again, the causes are hypoxemia and/or hypercapnia. Clinical significance is based on mechanical ventilation. You want to get oxygen to the vital organs, and you want to see oxygen and carbon dioxide levels get back toward normal range because that means that the patient can ventilate on their own. Clinical manifestations. With hypoxemia, you're going to see restlessness, cyanosis, confusion, tachypnea, and hypotension. Also with hypoxemia, you're going to have an increased respiratory rate and increased muscle tone. At first, your heart rate may be higher, but as this progresses, your heart rate will become lower. Hypercapnia is the complete opposite. You're going to have a decreased heart contractility, decreased respiratory contractility, and vasodilation. Arterial vasodilation. So instead of seeing cyanosis, you're going to see warm, flushed skin. Diagnostics. ABGs are the most accurate, and this gives you carbon dioxide and oxygen levels, as well as a pH and a bicarb level. Pulse oximetry is also very important because this measures how much oxygen is in your blood. A thorough assessment is also crucial. You want to listen for any irregular heart or lung sounds, look for signs of cyanosis, and assess level of consciousness. If the patient is not getting that much oxygen to their brain, they will have an altered level of consciousness. Chest x-rays are done mainly to find underlying causes. Traditional therapies include bronchodilators, and bronchodilators will open or dilate the airway, making it easier for the client to breathe. Antibiotics can be given if an underlying cause is infectious. Mucolytics are given to break up any secretions that may be blocking the airway. A combination I found interesting was inhaled nitric acid and exogenous surfactant. Inhaled nitric acid vasodilates, and exogenous surfactant decreases alveolar surface tension. Another traditional therapy would be to provide the client with fluids, preferably normal saline. This will give the client volume and help correct any hypotension and prevent sepsis. Lactated ringers would not be the fluid of choice because this is more for a patient that needs electrolytes such as sodium chloride, potassium, sodium lactate, and calcium. You're going to see this mostly given to burn victims or surgical patients. A respiratory drug that is used is Duoneb. Duoneb consists of albuterol sulfate and ipratropium bromide. Albuterol sulfate is a beta-2 agonist. These receptors are found in the bronchial smooth muscle, so when this combines, it dilates the bronchi and the bronchioles. Empirotropin bromide is an anticholinergic. This blocks the muscarinic receptors of acetylcholine, and this also vasodilates the smooth muscle and can protect against bronchospasms. A non-traditional therapy would be for the patient to lie in a prone position. This position will allow for oxygenation but should not be used long-term as it will not correct any underlying causes. Goals of treatment are to oxygenate. You want to get your organs oxygenated and get blood flowing. Supplemental oxygen can be provided. Mechanical ventilation can be done by intubation or tracheostomy. Non-ventilator treatments would include a CPAP or a BiPAP. There are many complications to acute respiratory failure. Organ failure would be the biggest, and this is caused by lack of oxygen to organs, like I've stated prior, and also inadequate blood flow. Pulmonary emboli and DVT are also possible. This can occur with air getting into the vascular space in the lungs or a DVT being thrown to the lungs. This can be prevented by giving heparin or using SEDs immediately on admission. That's when we get our DVT prophylaxis in play. But with heparin, you can have gastric bleeding because of decreased stomach juices or stomach ulcers. Sepsis is another complication, and this is treated with fluids and antibiotics. Again, you want to use the normal saline to get blood flowing through the patient. And sepsis is the body's reaction to tissue or organ damage. So where organ failure is a complication, the patient can be susceptible to getting sepsis. Lactate levels will be elevated, so you want to monitor for that. Ventilator complications include ventilator-associated pneumonia. This can be prevented by doing proper mouth care daily. And in an article I found by John Hunter, he states that tubes interfere with protective upper airway reflexes, preventing coughing and encouraging aspiration of secretions, which can be another cause of this. Ventilator-induced injury is when the tubes can damage the lung parenchyma. Prognosis for acute respiratory failure is based on how quickly the client is treated. If treatment is delayed too long, the prognosis for the patient will not be as good as if they were treated immediately. Evidence-based interventions and goals. Proper oxygenation via tracheostomy and/or ventilator. A tracheostomy should be delayed 2 weeks after a diagnosis just to ensure that the patient cannot ventilate on their own before you make such a more chronic decision. And a low tidal volume is going to be preferred because this gives the client less of a chance of getting a pulmonary infection. With a higher tidal volume, it can cause the alveoli to overstretch, which can cause a ventilator-induced injury. Non-invasive ventilation. This would include, again, your CPAP and your BiPAP, and this is not going to be as effective in patients with COPD. Goals, you want to evaluate ABGs regularly, and when the oxygen and the carbon dioxide levels are within normal range, then the patient is considered to be stable enough to come off the ventilator. Now let's take a look at the case study. John is a 24-year-old male with a history of asthma. As we talked about earlier, asthma in younger people makes a client more at risk for developing acute respiratory failure. He has been experiencing shortness of breath and wheezing for 2 days. There are those abnormal lung sounds that we need to be listening for. His oxygen saturation level is 86 and he has a respiratory rate of 35. With this being said, it's safe to assume that he has developed the hypoxemic type of acute respiratory failure. His ABG shows a pH of 7.37, a carbon dioxide of 70, an oxygen of 44, and a bicarb of 30. Based on this, the client would be said to be in respiratory acidosis. He is placed on 10 liters of oxygen and transferred to the ICU. He is put on a ventilator with a PEEP of 8, a respiratory rate of 12, and is receiving 100% oxygen. He is receiving 2.5 liters of normal saline to prevent sepsis and to treat his hypotension. Again, you don't want to give too much fluid because you don't want to fluid overload the patient, because then this can cause the patient to have even more breathing problems. After a couple of hours, a new ABG is done, and the findings are a pH of 7.28, a carbon dioxide of 40, an oxygen level of 98, and a bicarb of 23. Based on this result, John would be able to come off of the ventilator. His pH is a little acidotic, but this can be caused when the carbon dioxide level is corrected too quickly, or if there is an airway obstruction, and where he does have a history of asthma, it would be very possible. And these are the references. I hope you guys enjoyed this, and I can't wait to see what you guys have too.